repeat, what supplements do our patient need after weight loss surgery?
The British Obesity and Metabolic Surgery Society, or BOMSS, have produced some excellent guidance on managing patients after bariatric surgery in general practice. They've got lots of resources on their website, but for this video, we'll focus on their nutritional support guidance. I've included a link to this as I would really recommend reading this guidance in full. There has been some criticisms of this guidance because it tends to lean on expert opinion rather than clinical trial data, but I feel it's still a very valuable tool. I will, however, highlight some areas that I disagree with it as we work through it. Remember that this guidance isn't quite the same as NICE guidance. There's some flexibility in how we implement it, and it's really important that you work out with your colleagues how you would like to use this. This includes regional specialists like surgeons, endocrinologists, dietitians and biochemists, so you can work out how these protocols could fit into your region. Someone may have already done this work for you, so try and find out if there's any protocols already in place in your region before duplicating any work. So after a gastric band, the only supplement we need for our patients is an A to Z multivitamin. These can be purchased over the counter, so tell patients to look out for A to Z to make sure that it includes zinc, because this is really important. If someone's trying for a baby, they must start on folic acid 5 mg a day until they reach 12 weeks. But other than that, there isn't any other routine supplementation needed. Sleeve gastrectomies and gastric bypasses are much more involved, but thankfully they both require the same regimes, so we don't have to remember two separate ones. The multivitamin we use has much stricter criteria for these surgeries, as it needs to have some iron, some selenium, at least 2 mg of copper, and between 8 and 15 mg of zinc. We usually use Forceval for this because it provides everything in just one tablet, but this can sometimes be achieved by using 2 tablets of certain other multivitamins like Centrum Advance or some supermarket preparations. Further B12 supplementation is absolutely critical, and this must be given intramuscularly every 12 weeks to prevent permanent nerve damage. Alongside this, everybody needs iron to prevent anemia, and you can use this in any form that delivers 45 to 60 mg of elemental iron a day. The BOMSS guidance also suggests increasing to twice a day dosing for menstruating women, but to me this is outdated advice. There isn't really any argument for multiple daily doses of iron because it'll just cause more GI upset. Calcium and vitamin D supplementation is started alongside this to prevent osteoporosis in later life. For this, we use a dose of at least 800 mg of elemental calcium and 800 units of vitamin D, using whatever preparation is preferred in your area. In our area, we use Evocal D3 at a dose of 1 tablet twice a day. Finally, although it's not a supplement, most of these patients will be started on a proton pump inhibitor to both protect their operation site, reduce the risk of ulceration, and to reduce the risk of reflux symptoms and GI upset after their surgery. The key message with the proton pump inhibitors is these are not lifelong treatments. The surgeon will usually specify how long they want to continue it for, but in general this is around about 6 months after their operation. If they haven't set a course length, please check with the surgeon rather than continuing this drug indefinitely. We won't actually know the extent of the nutritional deficit until long after their surgery, so monitoring these patients is really important. I've seen loads of different regimes and discharge summaries, with some recommending very frequent blood tests in the first year after surgery, but this isn't needed under BOMSS guidance, and they advise that annual blood tests are more than enough. So I'd recommend telling the surgical teams that you will be doing annual bloods in line with BOMSS guidance and asking them if they have a problem with that. The list of tests is shown here, along with ones to be added for specific comorbidities which are marked with a C, and ones to add if patients are symptomatic, marked with an S. There's a lot of things to check here, so make sure your patients have appropriate recalls in place for each group of tests so nothing gets missed. In my surgeries, I've set up a quick code, which I've called #Bari, and this brings up all the supplements that are required and all the monitoring, including text to be copied into a diary entry for recalls. So check out my other video for quick codes if you'd like to do this at your surgeries. Some guides mention adding parathyroid hormone testing to these routine annual bloods, but this is another expensive test, and most labs will actually add it on for you if the bone profile suggests it's worth doing. So check in with your local biochemistry department what they do in your area before adding this to your recalls. There's loads of important medication related considerations after bariatric surgery. I actually feel there's more than I could condense into a video, so please read through the BOMSS guidance on this when you get a chance. But we'll cover some of the most important basics here. Immediately after the surgery, bigger tablets can block the opening created by the surgery. As a rough guide, if the tablet's bigger than the eraser on the end of a pencil, swap it to a liquid post-op. We should also avoid stomach irritating drugs like NSAIDs due to the risk of ulceration, or effervescent forms due to bloating or vomiting risk. But the most important consideration to me is how this surgery reduces drug absorption, reducing the effectiveness of a patient's medicines. For some drugs, we'll know immediately as blood pressure rises or we lose control over pain, but for others it can cause life-changing complications. Oral contraceptives become significantly less effective after bariatric surgery, so patients should ideally be swapped to non-oral forms pre-op. Narrow therapeutic index drugs or high-risk medicines like epilepsy treatments, transplant meds, Parkinson's drugs, or lithium all can have significant implications for a patient's health if their levels drop. Don't assume that these patients would be denied surgery because of being on these medications. I've personally encountered patients who had each of these conditions, excluding transplants, and they were still given malabsorptive surgery. Some teams are providing brilliant pre- and post-op medicine management, but unfortunately I have dealt with scenarios where a disappointing lack of care has been given to the medications, and this has significantly increased the risk of harm. If you encounter any patients on high risk or specialist medications who want to have bariatric surgery, it's important to seek advice from their specialist team to guide the management of their treatments to reduce this risk. So there you have it. You now know how patients should be managed properly after their bariatric surgery, and you know how to spot when they're not being managed properly. See you next time.